So thanks to everyone for joining us today. This is our first seminar for this academic year. And the seminar today is focusing on disaster risk management and reaching vulnerable groups. And we have three speakers: Professor Jennifer Horney from the Disaster Research Center at the University of Delaware, Dr. Sally Lindsay from Bloorview Research Institute, and Ryan Treves from Stanford University. And as we usually do, we will have the three presentations followed by a Q&A at the end. And just a quick rationale for the seminar. So there has been a growing focus in existing literature on the fact that disasters impact vulnerable groups, and the impacts of disasters are not equal. And while there has been a focus on the fact that some groups are more vulnerable to disasters, there has been less of a focus on what can be done to reach and support vulnerable groups during disasters. And that is what the seminar today will focus on. And the first speaker is the first speaker will be Ryan Treves from Stanford University. So Ryan, if you would like to share your slides.
Thank you so much, Maria. Thank you so much for the chance to present today. It's great to see all of you here. My name is Ryan Treves. I am a researcher at Stanford's Regulation, Evaluation, and Governance Lab. I studied Earth Systems and Statistics at Stanford, and I'm really excited to speak today on my team's work around wildfire smoke clean air centers, and specifically barriers and opportunities for improvement from California practitioner and community perspectives. This is a paper we recently published in Society of Natural Resources, and I'll be happy to share a link at the end of the presentation for those who want to dig deeper. Before I and a quick note, I'm not able to see the chat today, so if questions come up, feel free to stop me, or can save them for the end. Before I dive in, I want to acknowledge this work would not be possible without my team, Emily Liu, Stephanie Fisher, Ever Rodriguez, and Dr. Gabrielle Wong-Perotti at the Decisions Environment Lab at Stanford. Today, I want to really start off by outlining what is a clean air center and why should we care, before outlining our team's research questions around vulnerable groups and clean air centers, talking through our approach, and finally our findings and their broader significance, as well as some learnings about community-based research from the project. So in 2020, the skies of California turned a really dramatic orange color from wildfire smoke. The air quality was the worst anywhere in the world for several days. And these sorts of events are really projected to become more severe and more common globally with climate change. And they produce not only dramatic visuals, but really severe short-term and long-term health effects, from exacerbated asthma to negative reproductive outcomes. And public health officials often focus communications on individual level protective measures. For example, staying inside, using an air purifier, or reducing exertion. However, access to these strategies can be inequitable. For example, outdoor workers, those without safe access to housing, and low-income individuals may not be able to take these actions. Not only are these groups overrepresented in ER visits during wildfire smoke events, but they often face higher background exposure to air pollution and other types of hazards. So wildfire smoke events really have the potential to exacerbate environmental injustice. In the last 5 years, local governments, primarily in Canada and the US, have experimented with a new strategy of establishing clean air centers. So let's walk through what is a clean air center. A clean air center is a public building that's usually set up by a local government with air conditioning and air purification to provide respite to the public during a wildfire smoke event. And this may also serve as a cooling center, which folks may have heard of, two sorts of things under the umbrella of resilience hub type interventions. And so typically these centers will not allow overnight stays. They'll be certainly just open for a few hours during the day. And this is an example of what one might look like, at least in California. It's a public library serving other uses converted during a smoke event to help the public. So why focus in on clean air centers? Well, at least 50 or more centers were activated across the US in 2020 alone. And at the same time, our understanding of their efficacy is limited. Questions like, does the public use clean air centers? Do vulnerable groups? Are they any more effective than pushing individual level protective strategies? These are open questions. So far, studies have really only focused on engineering and air filtration questions with a limited evaluation of the field. And second, as these smoke events become more frequent, interest is growing among policymakers. California alone has allocated tens of millions of dollars for clean air centers in upcoming budget cycles. Bills have been introduced in US Congress, and public health experts in Canada and Australia have called for similar expansions. So we really need to understand these centers and how to make them effective in order for these investments to truly have an impact for those vulnerable groups. Now, what did we do? Well, I want to introduce you to Ever Rodriguez. Ever is the president and founder of the North Fair Oaks Community Alliance, or NFOCA, a grassroots community organization in North Fair Oaks, California. North Fair Oaks is located just south of San Francisco in the San Francisco Bay Area, if you all are familiar, and has a long history of grassroots organizing. It is an unincorporated community, meaning that it does not have its own local government, and thus public services can be more difficult for residents to access. What's more, it's primarily composed of immigrants from Mexico who speak little to no English, have lower incomes in the surrounding area, and have a higher asthma burden. So Ever heads up NFOCA, which focuses on health and equity of the residents of North Fair Oaks. And Ever and I got in touch in 2021 to discuss research questions and approaches that could both produce value for the community as well as insights about clean air centers more broadly. And I didn't come to North Fair Oaks to try to help, so to speak. I just hoped that the combination of Stanford's resources and NFOCA's years of experience could strengthen the groundwork for the community to self-advocate in the future. And at the end of the presentation, I would love to answer questions about the value and learning that I underwent engaging with the grassroots organization as a part of the project. Together, Ever and I came up with 3 key research questions. Number 1, how well are clean air centers in California reaching populations vulnerable to smoke? 2, what are the challenges that practitioners across the state face? And when I use the word practitioners, I mean those who are activating clean air centers. These can be emergency services staff, librarians, city administrators. Finally, how do residents in North Fair Oaks perceive or decide to visit a hypothetical clean air center? So no centers had been opened in the community in the past, and so we're interested in understanding reactions to a potential center. The methods we used were 30 semi-structured interviews, 15 with community members in North Fair Oaks. These interviews were in both English and Spanish, and interviewees were primarily Latinx, about 52 years old on average, mostly women, and then also 15 interviews with practitioners from across the state. So these are the locations that the practitioners were working in. All this was done virtually in the midst of the COVID pandemic. So that has some implications I can talk about later. What did we ask in these interviews? Well, to practitioners, we wanted to understand what were the logistics of your clean air center operation? How did outreach go? What about accessibility? How did you think about that? What are you thinking at this point about clean air centers and their efficacy? And what is your plan for the next wildfire smoke event? For community members, we were interested in, more broadly, what is your experience of wildfire smoke? And how do you protect yourself? At this point, we also showed them either a flyer or a script radio ad for a clean air center at a local building in the area, and tried to gauge their reaction. What would be, for example, important factors in your decision to visit or not? What would the barriers be? And then finally, how do you feel about the future of wildfire smoke in North Fair Oaks? So what did we find? Well, speaking to practitioners, it became clear that clean air centers are underutilized. Most practitioners observed only 5 to 15 users at one time, and they attributed this to a lack of amenities in clean air centers. In other words, not that much to do, and then also folks' attachment to their home environment, even if they were feeling the effects of smoke, really wanting to stay home. They also faced challenges with staffing and outreach, as well as finding a suitable space. The outreach was often rushed, as smoke can't be predicted long in advance, and practitioners weren't sure if vulnerable groups like the unhoused were aware of clean air centers. So broadly, while clean air centers could be valuable for some individuals, it was challenging to implement effectively for broader populations given the existing resources. A few quotes here. If you're not on Facebook or Twitter or checking on the city's website, which who does that, you're not going to find out about this. The air center is this band-aid that makes us feel good and provides a respite, but at the end of the day, it's not really addressing the issue because people are leaving and going back outside. The second quote was in reference to unhoused individuals. So what did we learn from community members in North Fair Oaks? So community members really felt anxious and unprepared for wildfire smoke, and they really showed an interest in learning more about it. There was a stark inequality in access to protective tools. Most interviewees had no air filter or air purifier. One even used a wet washcloth for relief from smoke. And at the same time, stark inequality in the Bay Area, another interviewee felt safe with his HEPA filter and his Tesla. So that was a really stark contrast. In terms of the factors that folks cited in talking about this hypothetical clean air center, transportation accessibility, in other words, close proximity to their home or having a bus system. Diverse outreach was mentioned as an important aspect, not just flyers, but talks in schools, segments on the TV and radio, translated into Spanish, and extended hours. For example, evenings and weekends were cited as important. Here are a few quotes from community members. I bring a rope, I bring food that will help me at the moment, but I never thought about the smoke. I don't have an inhaler, I don't have oxygen, I don't have a mask, something to cover me. I don't have it, I'm not prepared. And another mentioning, a lot of the Hispanic community, they don't have the means to say, I'm going to take off work, the air is so bad, I can take the day off. It would be ideal to have the late hours because a lot of people are getting home late. So broadly, there was a lot of interest in learning more, but several mentions of extended hours, outreach, and transportation as important aspects of a successful clean air center. We wanted to combine these results from both groups, on the left, perspectives from practitioners, and on the right, perspectives from the community, to understand how might we bridge the gap between what clean air centers are doing right now and how they might best meet the needs of vulnerable groups. So first, clear guidelines and community engagement to identify familiar, safe locations. Second, tools to help practitioners plan around public transit and resources for shuttle or vouchers could be a solution to providing transportation accessibility. And greater allocation of resources to meet staffing needs, including evenings and weekends, would improve the functioning of clean air centers. And then finally, tools and funding for practitioners to proactively share information in advance, not just the day of. So those are our results. Now, where to go from here? Well, it's clear that there's a profound need for broader wildfire smoke resilience tools and education, more than just a clean air center, to meet the needs of vulnerable groups. People had different conceptions of the ideal clean air center, so resources to understand a specific community's needs are critical. And enabling practitioners to engage with and learn from their communities is a key component of this. And then finally, activating a clean air center cannot be the end of the story. Our findings really underline the need for other interventions that allow vulnerable individuals to stay safe where they are. Developing safe, affordable housing is first and foremost a part of that. That's the first step. And then increasing access to at-home tools such as air purifier distribution would also be incredibly valuable. broadly vulnerable groups like the unhoused, like outdoor workers, like those non-English speakers, need holistic approaches to wildfire smoke resilience that build trust and enable participation and learning to address underlying inequities. I want to finish off with a few notes about our position as researchers faced with this environmental injustice. I found community-based research to be a valuable framework to examine power and positionality in my work with North Fair Oaks. In particular, I want to mention a work from these scholars as influential in my thinking about community-based research. I think that as researchers, we have a responsibility to really learn about the legacies of harm that research on communities has caused in the past and present, and continue to break that pattern going forward. I think we also have a responsibility to amplify the voices of community members and set up meaningful participation at every step of the research process. And finally, understand exactly what research can and cannot do for a community's needs in any given project. With respect to North Fair Oaks in particular, since we have published the paper, the community received public funding for 5 large commercial air purifiers, which could be deployed in clean air centers during the next wildfire smoke event. So we're excited about that. I think North Fair Oaks has an opportunity to, almost for the first time, create a clean air center that really centers the community's needs and incorporates some of the takeaways from our research, strategically designed for the most vulnerable, to create a success story that could be replicated elsewhere. I will wrap it up there. I'm excited to hear questions. Thank you so much. And here's my contact information.
Thank you, Ryan. That was a really fascinating presentation. And I'm sure we'll have a lot of questions, but we will carry on with the next presentation and then have a Q&A at the end. So, Professor Horney, if you would like to share your slide.
Sure, thank you. I think we're, kind of going from local to global in a sense, and maybe thinking about how some of those larger structures can contribute to some of the need that was raised on the last slide. So I'm actually going to focus on some work that we're doing now related to women in disasters, and speak a little bit generally about COVID-19 and some funded work that we have, and then some challenges going forward. And so just to sort of speak from the same playbook, I guess, when I'm talking about emergencies and disasters, I'm talking about disruptions in the terms of disasters, disruptions that exceed the capacity of the community, and coming from a frame in which we think about disasters and emergencies as not natural, but a result of how communities are structured and resources are allocated. And so I think one interesting frame for exploring that community structure and resource allocation and the implications to vulnerable groups and disasters are to look at a very large vulnerable group, which is women. So according to the United Nations, women do at least 2.5 times more unpaid work than men, and this is in a non-disaster time. And the New York Times estimates that's worth about $10.9 trillion globally. And so we just see an amplification of that during disasters in many different ways. The gendered impacts of disasters are well known in terms of inequities in morbidity and mortality. We know that women-led businesses are impacted more severely during emergencies and disasters, and also that humanitarian responses are most effective when women are directly involved. And there's some very interesting research about even basic items like receiving individual disaster assistance in the US from the Federal Emergency Management Agency, and how that is structured for family units and heads of household, and may lead to women having less access to those types of financial assistance and recovery funds. And so we've actually looked at this quite a few different settings, but this is the state of Florida, which had 4 major hurricanes in a single year. And so we know that the disparities between men and women can increase during disasters. And I mentioned disparities with access to financial assistance and recovery aid, but there's also the potential to lose safe housing. Again, that need to remain with a family unit as more traditionally defined to qualify for assistance. And in studies, we've actually been able to show a dose response effect. And so in the instance of domestic violence, more days of a declared disaster equals more violence against women. So in the case of these Florida hurricanes, 78 excess assaults could be attributable to those disaster declaration days. And so we really sort of saw this highlighted during the COVID-19 pandemic because of the relative collapse due to the pandemic and the public health response to it of our community structures. And so we saw a failure of institutional supports, a lost opportunity for paid work, with all of these that impacted women more, lost access to other types of supports. And while, with schools and daycares closed and other types of physical distancing and the use of virtual courts and other types of things. And so while COVID is certainly unique, I think there are lessons there that can be applicable to other disasters. And so if we look especially at the beginning of the pandemic, 40% of men reported that their female partner was the sole person responsible for providing care for kindergarten to grade 12 children. About 60% of mothers reported deterioration of their mental health, which was about twice the rate of fathers. Not that the pandemic wasn't hard for fathers, it was just a lot worse for mothers. And these negative health impacts of this family care inequity are only more pronounced in lower socioeconomic mothers and female guardians. And so we also know that this is going to be a multi-generational impact because in the US, minority children were about 5 times as likely to lose a parent or grandparent caregiver to COVID. So I mentioned the job losses. So there was an exodus of the female and female-dominated workforces here in the US. There was a lot of media coverage about women in science and women in academia. And this is a chart from a National Academies of Sciences study of work effectiveness of academic women in working in STEM. And so, you can see that although they were working more hours and felt a higher workload, they also felt decreased productivity and challenges around remote teaching and research. And so working more hours and getting less done is a very challenging position to be in. And again, we saw the most impact on working mothers and Black women. Although interestingly, senior women also left the workforce in quite high numbers. And I have interesting conversation with that around my students. And women clinicians were at higher risk of burnout than men. Oops. And so other things that happen in disasters more generally, but obviously very critically during COVID, is a reduction to access to care. So when facilities are damaged or healthcare workers cannot make it to work, appointments in general post-disaster are canceled or missed. And there's a lot of research on that in different populations, including veterans and other subsections. But what we saw post-COVID, because it was a public health and emergency, is a reduction in access to care to basically zero. So we can see that for Yale New Haven Health, which is I think the third largest healthcare system in the United States, hospital system in the United States, that breast cancer screenings basically went to zero in April of 2020. And that may be expected, but perhaps more interesting to consider now is that it hasn't rebounded. So here in the US, we've continued to lose ground on health metrics like childhood immunizations and cancer screenings and other things. Even through the end of 2022, those numbers were still going down and going down in inequitable ways. So the gap was widening between non-Hispanic whites and people of other women and people of other races. And so a lot of challenges to women's health associated with disasters. And there's been a good bit of literature looking at birth outcomes, but there are also other important factors like access to contraception and other things. And so much of the work that we've been doing lately has been looking specifically at domestic violence as a shadow pandemic during COVID. The National Domestic Violence Hotline in the US saw large increases in online chat, in victims identifying as Asian, and in the need for protective and restraining order. And there's a discussion here in the US, and I think this is also important to consider in disasters more generally, that we need new types of community advocates. And so are there frontline workers or others that need to be trained in understanding the types of disparities that vulnerable populations face in disasters so that they can recognize those and be knowledgeable about providing information about assistance. So I don't really like this graph because there are many ways to think about disasters as being impactful without thinking about them being as billion-dollar disasters. But the frequency and severity of disasters is increasing. And someone born in 2020 will experience about 3 times as many climate disasters as someone that was born in 1960. So we really need to figure this out. Heat waves and wildfires, as were talked about before, sort of go hand in hand, potentially with drought, in thinking about this acute and slow onset type of disaster. But these are just going to become business as usual, and not so much thinking about. And then, of course, as an epidemiologist, we're very concerned about the reemergence of measles, which has a very high reproductive rate compared to COVID and other potential pandemic threats. And whenever people say, "Oh, who could have known?" I often want to think back and say, like, we all could have known, because we've had for the last 20 years, we've had SARS and avian flu and swine flu and Ebola and Zika, and I could go on. So these threats are of future public health emergencies and disasters that are closely linked to climate change and other sort of quote unquote natural disasters, are are really critical to think of in that way. And so I just wanted to close with a plea, I guess, to consider how this works within the larger global frameworks, because I think that to make progress, even here in the US, but certainly globally on these issues around the inequitable impacts on women of disasters, we have to work within the Sendai framework for disaster risk reduction and the Sustainable Development Goals, focusing on recognizing, reducing, and redistributing work so that we don't come into the disaster phase with such inequality in those systems. And in particular, there are some areas in which we could focus on goals that have been set for 2030 related to pregnancy and postpartum supports during disasters and emergencies. And we could do a better job of understanding and applying the lessons learned from COVID, considering that they're unique, but figuring out what worked. So just for example, are there services that can continue to be provided virtually that would serve women well and eliminate the need for things like childcare or transportation? And so those are, of course, adopted for COVID, but would work in any kind of emergency or non-emergency setting. So this is our research team. Some of this work is supported by a National Science Foundation grant, and I'm happy to discuss and answer questions. Thank you.
Thank you so much, Professor Horney. I'm sure there are, again, many questions, but we will move on to our next presentation and have a discussion at the end.